Good morning, and welcome to the University of Alberta Child and Adolescent Psychiatry Grand Rounds. I'm Dr. Alice Liang, and I'm your moderator. We're very grateful to be partnered with the Faculty of Medicine and Dentistry Office of the Lifelong Learning and Physician Learning Program. I'd like to do the territorial acknowledgement. The University of Alberta, its buildings, labs, and research stations are primarily located on the territory of the Nehio or Cree, Nietsitape or Blackfoot, Métis, Nakota or Stoney, Dene, Haudenosaunee or Iroquois, and Anishinaabe or Ojibwe Saulteaux lands that are now known as Treaties 6, 7, and 8 and homeland of the Métis. The University of Alberta respects the sovereignty, lands, histories, languages, knowledge systems, and cultures of all First Nations, Métis, and Inuit nations. So a reminder, use the chat feature if you have a question about logistics. And if you have a question for our speaker, please use the Q&A feature of the webinar. So I would like to introduce our speaker. Dr. Jacquelyn Paquet is an exceptional child and adolescent, so specialty resident at our University of Alberta, and also a PhD candidate with a focus on inequity in psychiatric service access and use in Canada, with aims of optimizing service allocation and delivery. She was raised in rural Alberta, shaping her research and clinical focus, completing rural rotations through her medical school and residency training in Alberta and Yukon. She has presented locally, nationally, and internationally on her research and collaborates with national leaders to address psychiatric service inequity, and has multiple published and upcoming manuscripts focusing on health inequity. She has received local, provincial, and national awards related to research, advocacy, and leadership, including her current leadership trainee roles with the CPA, APA, and KCAP. We are delighted that she can present on her research today as an emerging leader.
Wonderful. Thanks so much for the introduction, Dr. Liang. And also thank you so much for that wonderful land acknowledgement. I'm just going to put my slides into presenter mode, and then I'll share my screen. Okay. Okay, so as Dr. Liang highlighted, my research focuses on health inequity, and so today I'll be discussing how epidemiology meets practice specific to child and adolescent psychiatry. And for this reason, I'll be looking at trends in mental health by diagnosis, setting, and geographic location before and after the pandemic, with a focus specifically on child and adolescent psychiatry, although this research spans the lifespan, so we have other research looking at adolescents and emerging adults and geriatric populations as well. I have no presenter disclosures in any sense, no financial support, no conflicts of interest, and no potential biases. So I'm just going to skip through those slides. My objectives for this presentation are to examine the temporal trends, the demographic and contextual variables in psychiatric service utilization by age, sex, and geographic location, and that's looking at rural and urban populations. I also will be discussing how some of these disparities exist, especially between rural and urban youth, and discussing the implications for health equity. And then lastly, looking at some of the clinical and systemic level implications of how these findings exist, and specific for early intervention, resource allocation, and service planning in child and adolescent mental health. So just to start off with some background, when we think about the initial components, I'm going to start first off with the impacts of the COVID-19 pandemic. So when we think about the COVID-19 pandemic, there were significant impacts on youth mental health globally, which has really amplified disparities, especially in regards to care access. As many would appreciate, there's multiple stressors that likely contributed, and these include factors such as social isolation, family hardship, economic instability, disruptions in school, parental mental health concerns, and that worsened mental health for both parents and children alike. There were also a lot of lifestyle changes that we can also appreciate, including increased screen time, reduced social interactions, decreased extracurricular activities, physical inactivity, and how those in itself likely further contributed to mental health concerns, especially with regards to school closures and loss of support services, especially when we think of the developmental milestones across our children into our development or into our adolescent years and how that likely impacted some of those components as well. Furthermore, the pandemic-related mental health impact showed increased rates of both depressive and anxiety symptoms, especially among adolescents and among females. And there was some mixed trajectories in the literature in regards to what recovery really looked like. And although the restrictions likely helped prevent some of the spread related to COVID, these measures reduced access to mental health services, especially with early impacts on virtual care access. When we look at some of the Canadian pediatric mental health trends, I'm just going to start by prefacing that most of our current literature either has a smaller duration of their study period and or they have not looked across the different areas in which people access care. So only looking at outpatient services or outpatient and emergency services, or just having like maybe 1 or 2 years of data. And so that has for sure impacted some of the similarities, but also some of the differences with our literature. So looking at some of the big studies, BC did a study, and ironically, they were able to link school enrollment data and physician health visits, as well as having access to prescription medication data. And they found that both depression and anxiety were the most common diagnoses, followed by ADHD among students aged 13 to 16. Multiple studies from Ontario. However, overall, one of the studies, this first one, was looking at emergency visits and inpatient admissions, and they found that there was the largest decline in service use among adolescents between 14 and 17 between 2019 and 2021. And there was reduction in substance-related disorders and anxiety disorders over that same period of time. A different research group looked at outpatient care, and they found that there was declines at the start of the pandemic, and then there was an increase and remained elevated anywhere from 10 to 15% above expected levels following and even during the latter parts of the COVID-19 pandemic. And the service use was greatest among females, especially for mood and anxiety disorders. And then the last study was one of the longer duration studies that we found in Canada, and again, looking at outpatient services, and they found there was higher outpatient visits for females and adolescents, especially for mood and anxiety disorders. So then thinking about some of the disparities in care access, there are multiple barriers to mental health care access among Canadian youth, and these are amplified among our rural groups who have further difficulties in terms of access to primary care, closure of emergency departments throughout Alberta over the course of the pandemic and even post-pandemic. And in addition to this, that the challenges related to the shift to virtual care, including the infrastructure to host virtual care options in some of these rural communities, connectivity issues, broadband issues, device limitations, and even privacy concerns, limited even those further options for virtual care among some of our more vulnerable populations. And then, as I mentioned, there's significant impacts in terms of access to care generally, and these were amplified over the course of the pandemic. So I'm going to go over our study in a little bit more detail, and then we'll go through some of the data and how that's shaping where we're at now. We actually did a retrospective population-based cohort study using physician billing. Our population included children and adolescents 0 to 17 who were seen by a physician for a psychiatric disorder. The populations from 0 to 5 had to be removed from this sample given the low the low sample size and just the ability to really look at some of the diagnostic characteristics of that population. So hopefully with more years of data, we'll be able to look more closely at that population in itself. We used administrative records from 2017 to 2022. So we had 6 years of data. And then we adjusted the data for non-normal distribution. And then following that, we completed a variety of different analyses, including descriptive statistics. One way ANOVA is looking at the impact of the pandemic on rates of presentation, and then did some general linear modeling, looking at our independent variable of presentations with various dependent variables as well, or independent variables, sorry. So in terms of our variables, these are what we are looking at. So we have age, less than 1 to 5. Both of these had to be removed from this specific sample. So we're looking primarily at our population 6 to 11 and 12 to 17. From now on, the 6 to 11 will be referred to as children. The 12 to 17 will be referred to as adolescents. We had biological sex of female and male, and then geographic location, we combined to have an urban and a rural cohort. And then in terms of healthcare setting, we actually had access to outpatient, emergency, and inpatient data. So looking across the spectrum of service access and utilization. And then we looked at pandemic phase. And so we combined 2017 to 2019 to include pre-pandemic data. Pandemic would be 2020 and 2021. And then we have 1 year post-pandemic data, which we're hoping to expand on in the next couple of years. So we're going to look a little bit at some of the temporal trends. And so our first one here is looking at our outpatient psychiatric presentations per 100,000. And just to orient everyone, the light blue on your screen is related to anxiety disorders. The darker blue or the purple is neurodevelopmental disorders. The yellow/orange is mood disorders, green is substance use disorders, and then pink is eating disorders. And so as you can see, there was a surge of outpatient presentations during the pandemic for both anxiety, neurodevelopmental, and mood disorders, further surpassing the pre-pandemic rates. And even following in that 2022 category, both our neurodevelopmental and our anxiety disorders were greater than that of our pandemic rates and even our pre-pandemic rates, and similar to that of mood disorders. So all three of these categories showed both a pandemic increase and remained elevated in that post-pandemic phase. So next, looking at emergency. So in the emergency department, data looks a little bit different. There's a new category, so it's going to have this purple color, which is non-suicidal self-injury. We don't have access to specific suicide-related data. However, this would be presentations for those self-injurious behaviors. Overall, we see that and then non-suicidal self-injury as well. And similar to previous data, we're kind of right around that category of returning to our pre-pandemic levels. However, that varies between category. And then lastly, we're going to look at inpatient presentations. Again, slightly different than our outpatient data. However, anxiety disorders were the most prominent reason for admission over that pandemic. Quite a significant surge noted in terms of that peak rate at 2021. We see also that same increase, maybe not to the same extent, but especially in regards to neurodevelopmental disorders, mood disorders as well. And then seeing some changes, especially in regards to eating disorders, which we didn't necessarily see in some of the other data. And then following the pandemic, again, there's different rates of reduction and return either below or at pre-pandemic levels. So this is what guided our initial discussion of, what is going on with the data, what do we want to do in terms of analysis, and what are we really seeing in terms of what we're seeing between the three different presentations or locations of presentations. And so from this, what we wanted to do is really look at some of those descriptive findings and see what was actually happening with the data, and looking at some of those variables that we are chatting about in terms of what we're actually seeing between different groups in terms of age, sex, geographic location, et cetera. So when we look at our demographic variables, we had a large sample size. So we had 1.2 plus million data points and encounters to examine over the 6 years. Over the course of time, um, children accounted for approximately 30% of all presentations, whereas adolescents represented the majority. And I think we can all appreciate that that is likely the case in what we're seeing clinically as well, especially when we think about emergency presentations, outpatient and inpatient admissions. There were similar rates of presentations for both males and females, females slightly more than males. And then in terms of our geographic setting, urban cohorts accounted for the majority. So 82% of all encounters, whereas less than 20% were for our rural cohorts. And then in terms of healthcare setting, most of our presentations were in the outpatient setting. So approximately 81%. And then emergency and inpatient accounted for the remainder of those presentations. When we look at specific diagnoses, internalizing disorders, which included mood, anxiety, and eating disorders, accounted for about 52% of all encounters. And in addition to this, we're seeing that anxiety disorders accounted for most of those presentations in itself. What you can see as well, just to make note of, is that there's a delta change that we can see both in COVID-19 and post-COVID-19 data. And anxiety disorders rose tremendously. So there was a 33% increase over the course of the pandemic, and then a further almost 20% increase in that post-pandemic phase. And we'll see similar results in terms of mood, maybe not to that same extent. So 17% increase over the pandemic, and then another 4% increase in the post-pandemic phase. And then eating disorders had a very large increase over that pandemic phase of 44.8%, despite accounting for less than 1% of all encounters. When we look at the externalizing disorders, including neurodevelopmental and substance use, we see that that accounted for about 47%. Again, we're seeing that there was an increase in neurodevelopmental disorders over the pandemic. And compared to other disorders, we're actually seeing a larger increase in that post-pandemic phase, which we'll talk about later in the course of our time together. And substance use disorder remained relatively stable, although there was a slight increase over the course of the pandemic. And then lastly, thinking about our non-suicidal self-injury, that accounted for, again, less than 1%, but we're seeing increases both during and post-pandemic as well. So from that data, what we're going to talk about now is what is actually happening, how are some of those independent variables impacting that dependent variable of presentations. And we're going to look at all those diagnostic categories together. And then following that, we'll look at each individual diagnosis and how that has been shaped by various variables as well. You'll notice that there's an effect size here to the side, and I've bolded some of those really large effect sizes throughout the remainder of my tables as well. So when we look at all diagnostic categories, what you're going to notice is that age, sex, geographic location, and healthcare setting were all significant. This, again, likely is related to kind of our basic understanding of anxiety. However, more common among our females and our adolescent populations, more common among our urban cohorts, and more commonly seen in the outpatient setting. There was an interaction between sex and age. So what that looks like is that both of those variables actually relate together. And so what we're noticing is that adolescent females exhibited higher rates of psychiatric presentations compared to adolescent males, and adolescents had greater rates than the children did. So we're going to look at individual diagnoses next, and that will help shape some of these categories as well. So looking at anxiety disorders, similar to what we are seeing with all diagnostic categories, so sex, age, geographic location, and healthcare setting were all significant. Pandemic phase was also significant for anxiety disorders. So what we're seeing with anxiety disorders is we're seeing this more among females, among our adolescent population, more among our urban cohorts, and also in the outpatient setting. In terms of pandemic phase, it was more likely to be seen during the pandemic. So that's where that significance comes from. And similar to when we looked at all diagnostic categories, not surprisingly, sex and age correlate together as well. So high rates among adolescent females, and age in healthcare setting also had an interaction where adolescent had more presentations across all healthcare settings as well. So next we're going to look at mood. So this is another one of our one of our more common diagnostic categories as well. So similar to that of anxiety disorders, the same variables were also found to be significant. So pandemic phase, sex, age, geographic location, and healthcare setting. And you're noticing that the effect sizes are also found to be quite large for quite a few of these variables, and those are the ones, again, bolded for us. For mood disorders, the trends appear quite similar. So we're seeing this among females, among adolescents, our urban cohorts in the outpatient setting, and as well, we are seeing this more during the pandemic as well. The same key interactions also exist, so more encounters among adolescent females compared to males or to children, and age and healthcare setting, more encounters across healthcare settings for adolescents across all three settings. So next we're going to look at eating disorders, which is our last internalizing disorder that we examined. The same categories are also found to be significant. You're noticing the same variables also have a large effect size. So again, those are the ones that are bolded. However, slightly different findings. So these are more common among female adolescents in the outpatient setting, among those that are from urban cohorts. However, for eating disorders, it was actually in the post-pandemic phase. So what we kind of seen initially was there was that increase in the pandemic, and then there was a further increase in that post-pandemic phase, and that was found to be significant for them. So we're going to shift gears slightly, and we're going to look at substance use and neurodevelopmental disorders. So looking at neurodevelopmental disorders, again, slightly different than what we are seeing with some of the internalizing disorders. But again, we're finding that the sex, age, geographic location, and healthcare setting were all predictive of those psychiatric presentations for neurodevelopmental disorders. Pandemic phase was not found to be significant for neurodevelopmental disorders. For this specific group, age was significant, and again, among adolescents. For sex, it was males. Geographic location, it was urban cohorts again. And then for healthcare setting, we found this to be similar to all the others, and it was found in the outpatient setting. The same interactions we're noticing. So we're seeing the same trends in terms of what's interacting with what. So among our key interactions, there are more interactions among male females compared to female children. And again, we're seeing more encounters among our adolescents as well. And then for age and healthcare setting, adolescents had more encounters across all three healthcare settings as well for neurodevelopmental disorders specifically. Okay. And then for substance use disorders, these were more common among adolescents. Sex was not found to be significant. Geographic location wasn't found to be significant, and neither was pandemic phase. And then for healthcare setting, it was still the outpatient setting, although we were seeing increasing amounts even in the emergency setting as well. And both age and healthcare setting were found to be have quite large effect sizes for this population. And again, like the others, we found that there was more adolescent presentations across all healthcare settings. So our last table that we're going to look at in a little detail as well is looking at our non-suicidal self-injury. Something to note for this is that we don't have any outpatient data. So this data is only looking at emergency and inpatient rates. So this was not a diagnostic category that was collected for the outpatient setting in any sense. And so for this, what we were noticing is that for our non-suicidal self-injury, age, healthcare setting, sex were all significant, and they are more common among adolescent and females during the pandemic, and of course in that emergency setting. And the same sex and age category was also found to be significant. So this is a lot of data, so I wanted to just take a break a little bit and highlight some of the overall and demographic predictors, just to summarize the data in a little bit more detail, but also to give ourselves a sense of where some of these overlapping principles might come from and what it might mean as well. So when we think about the overall findings, especially in regards to post-pandemic service use, what we were finding is that there was an age and sex predominance. So, what this really highlighted to us throughout the data is that adolescents and females were the strongest predictors of psychiatric service utilization. And when we think about that, when we just break it down a little bit, we know that adolescents had a greater increase. So, we had a 25% increase to the pandemic, and then a further 22% increase in that post pandemic phase. And there was a greater increase for females across the pandemic. So they had a 36% increase in service use compared to male cohorts. So both females and adolescents might have some specific vulnerabilities that must be considered. In addition, there was a really high statistical effect size, so zero point 0.5, for instance, or even greater. And there was a lot of those sex and age interaction effects noted as well. So when we think about that together, those are some of the vulnerable populations that we really need to think about, especially when they're driving that service utilization and what that might mean in terms of longstanding use, but possibly even some intervention strategies. In terms of setting of care, the majority of the increased service use was driven by outpatient care demand. And I don't think anyone's really surprised by that. Most of our care does occur in outpatient settings. However, this also signals that there could be the risk and even possibly currently some limited community capacity and potential strain on community providers. And I think we can all appreciate how long wait times can be in terms of accessing outpatient psychiatric care, especially for our children and our adolescents. And just thinking about how those will interact with some of the other variables that we're thinking about, especially thinking about regional centers. So thinking about, Fort McMurray, Medicine Hat, Lethbridge, Grand Prairie, and then thinking about our rural cohorts and how that limited community capacity is even that much more amplified for those populations, and how if we're not accessing outpatient care, the cost of service use by utilizing emergency services or requiring inpatient admissions when we're more unwell can really shape and guide the need for further outpatient services. And then lastly, looking at temporal trends. So service rates dropped initially during that 2020 lockdown, and then there was a significant rebound, and rates exceeded pre-pandemic levels by 2022, which was more notable for certain diagnoses than for others. So again, just trying to think about how these all go together, especially considering, the role of isolation and disrupted routines and reduced service access. And really what these findings are highlighting to us is that there's heightened psychological distress as a result, and that there has been and likely will continue to be adaptive service delivery shifts to meet the demands that are currently ongoing. So next, just kind of thinking about those surges and the geographic disparities by each diagnosis. So we'll start with just a summary of mood and anxiety disorders. So the surge, when we think about it, was, there was a significant sustained increase in mood and anxiety disorders. What we're thinking is likely impacting this trend is academic disruption, social isolation, and how those pieces in itself might further drive worsening of psychiatric symptoms, delayed access to care, and again, sequelae of what that might look like. In addition, when we think about some of the disparities, we know that urban rates for mood and anxiety disorders were significantly higher than that of rural populations. And previous research have not highlighted that children and youth in urban cohorts have higher rates of mood and anxiety disorders. Rather, we think this is likely related to service use and access because the rates are actually similar when we look at overall symptoms, which might highlight more the limited access to service in itself rather than truly a difference in terms of diagnostic abilities between our urban and our rural cohorts. For eating disorders, they actually experienced the largest proportional surge. So remember, we actually had a 44% increase during the pandemic and then another increase in that post-pandemic phase. And they had the strongest sex and age effect as well. When we look at some of the disparities, especially geographic, there were lower rates of eating disorders in rural areas, again, likely suggesting underdiagnosis and or significant access to care issues, especially when we think about eating disorders and oftentimes needing some additional supports in terms of dietary supports, psychiatric care, as well as psychological supports. And when we think about our current access to some of these services in Alberta, a lot of times our rural communities face repetitive turnover of their mental health and addiction clinics in itself. And even access to a dietitian may be something that's not feasible in some of these rural communities. And so just thinking about how even beyond psychiatric care, how access to the care needed for something like an eating disorder might have significant impacts in terms of diagnostic clarification. In terms of neurodevelopmental disorders, there was a delayed but a sustained rise, again, possibly due to diagnostic backlogs from school closures. I think we can all appreciate how important our schools are in terms of identifying at-risk children and youth who are demonstrating various neurodevelopmental disorders and how that in itself might guide or even encourage a referral to psychiatry or even to like a psychologist, for instance, or to engage in neuropsychological assessment or even like a psychoed assessment. And so that closure period might have had a significant impact in terms of those increased rates of neurodevelopmental disorders. And I think, again, seeing the results in that post-pandemic phase, that might have actually highlighted that delay rather than truly a significant change in terms of the diagnostic abilities of neurodevelopmental disorders. For neurodevelopmental disorders, there was no rural urban difference. So, again, highlighting that likely similar rates of presentations. Again, that might actually impact how people are accessing care, how service use is delivered, funding for schools and access to some of that testing ability might actually vary as well. So next, in terms of thinking about our substance use disorders, they were relatively stable in terms of rates during the pandemic. What this could highlight as well is that it could actually be a dichotomy of reduced access to substances with the closures and the restrictions in terms of in-person gatherings, while at the same time there might have been increased supervision as parents were working from home and there was more adult supervision in that regard. In addition, it could also reflect that there was limited access to treatment over this period of time. So despite the rates being relatively stable, one has to think about what might have contributed to that rate actually remaining stable, while a lot of other psychiatric diagnoses demonstrating significant differences. And then lastly, in terms of non-suicidal self-injury, there was a notable increase, especially among adolescent females in the emergency setting. So just to remind individuals, there was an 18% increase during the pandemic and then another 10% in that post-pandemic phase. Again, thinking about what that might signal to us. So when we see those increases, is there an underlying diagnosis that has not been identified? It's highlighting psychological distress. It might impact other diagnostic categories as well with that increase. In addition, there was an urban-rural disparity. So again, suggesting that rural youth may be presenting less often. However, it actually might indicate that there wasn't the same opportunities to present for non-suicidal self-injury. Again, as I think a lot of us could recall from the news and from other sources of media, many of the rural emergency departments had either reduced hours over the course of that 2020 to 2022 and continuing even into now, and some actually had to close. And so thinking about how some of those social determinants of health might impact the diagnostic rates of some of these diagnoses, thinking about access to transportation, access to primary care, even the ability to seek a primary care option to treat those injuries might actually be limited. And so, again, it might suggest that they're presenting less often. However, again, recognizing the climate in terms of healthcare in rural Alberta, it might actually indicate more that there was less access to service for our rural cohorts. Okay. So now that we've kind of gone through the data, I want to take a few minutes just to think about the implications of these findings and what it really means in terms of health equity, what it means in terms of some of the clinical implications, as well as thinking about what that means in terms of systemic implications as well. So when we think about our impacts on health equity, what we're often seeing is that one of the areas that I think is of utter importance is addressing the rural service gap. So the lower rural rates for anxiety, mood, and eating disorders signals more inequity and possible underdiagnosis related to service access. So most communities are either relying on telepsychiatry to access psychiatric services, but even pediatrician services. In addition to that, many have limited access even to primary care. You might have to book an appointment 8 weeks out to see a primary care physician. It might not even be yours, just depending on how that system works in those communities and how that in itself could really impact rates of diagnostic or diagnoses for a lot of our psychiatric disorders among our children and youth. Well, one of the other aspects to really think about is that we really have to adapt our care models. So, thinking about ways to develop and fund flexible community-based treatment options, virtual outreach services, but also thinking about those that kind of overcome infrastructure limitations. So, some communities, for instance, have access to um, specialist clinics, monthly or every couple of months in order to see people in person and at least make those initial connections. Again, another big aspect of that is that trust in those communities. So the primary care trusting the specialists because there's a relationship is likely going to impact the trust that the patients have in that provider to provide those supports and that treatment. So again, thinking about ways in which communities can identify, like how we can identify community needs and how we can meet those community needs, and thinking that not every community is the same, not every community has the same access. And even when you think about that geographic location, somewhere way up north, like High Level, is very different than someplace such as, Whitecourt, and that distance and proximity to subspecialty and specialty services is quite a bit different. In terms of our clinical focus, thinking in one way to prioritize early intervention, so focusing at resources and non-pharmacological strategies on high-risk groups for mood, anxiety, and eating disorders is one of the areas, as well as neurodevelopmental disorders. So for many communities, access to psychological supports to even access therapy such as CBT, DBT, et cetera, might be quite limited in most of these communities. And thinking about ways that might be integrated into the community or ways that it can be provided in virtual ways or in other ways might be something that really needs to be thought about and expanded upon for those that do have access. And then optimize intervention timing. So designing programs that respond directly to pandemic related stressors. What this data really highlighted is that the system was just kind of holding itself together. And with the pandemic, we've seen where those tipping points really were and seeing significant impacts in terms of diagnoses over the pandemic and post-pandemic periods highlights a need for, again, a sustained workforce, an expanded workforce, especially when we think about possible subsequent pandemics and what our system will look like as we continue to have difficulties meeting pediatric mental health care in Alberta and beyond. This is an international issue. So thinking about strategies even at this point and interdisciplinary approaches to target and to optimize intervention opportunities. And then lastly, thinking about a system reform. So one of the areas that we noted the most was how much of our care is in the outpatient setting. So remember, about 80% is in the outpatient setting. And so alleviating the burden on emergency departments requires expanding community-based and primary care mental health services. So thinking about the economics of our system, thinking about wait times in our emergency departments, ways that we can alleviate that burden is really expanding access to community-based care. And I think this is way beyond just child and adolescent psychiatry. This is looking at therapy. This is looking at expanding CanReach, et cetera, to think about ways in which we can work interdisciplinary and with our colleagues across both medicine and other specialties to meet the mental health care needs of our children and youth in Alberta. Again, this is a long system reform requirement. However, thinking about ways that we can support that from our subspecialty lens would be one way to think about this moving forward. And then in addition to that, enhancing data integration. So Alberta is quite unique in that we often get retrospective data, and the data for health, education, et cetera, they're all its own category. And so the ability to integrate the data into system reform and into resource allocation is actually quite difficult because the data is always retrospective. So we're always getting data from, the last quarter or the last year, which makes it really difficult in terms of needing to respond, especially in the case of a pandemic. Other places in Canada, so BC, for instance, can integrate education and healthcare data. So that can help in terms of what they're seeing in schools, what they're seeing in health, and kind of bring those together to shape interventions. And then even in other areas, so Scandinavian countries is one that stands out to me. They have a way of integrating a lot of data into one pool, which allows for a lot of that innovation, but also in terms of the resource allocation and quick response to needs. So I think in order to really engage in real-time surveillance and tracking those surges, that would require some increased data integration. So that's part of some of the work I'm doing with some of the other areas as well, is thinking about how can those be accomplished, because that would allow for more opportunities for timely, equitable service allocation as well. So I wanted to make sure we had a lot of time. I wanted 15 minutes in order to answer questions, discussion, etc. I've included my references here. And so there's 2 pages of references. And at this point, I'm willing to take any questions, comments, feedback. And thank you so much for taking the time to listen to my discussion today.
All right. Thank you very much for your wide-ranging and enlightening presentation. Before we head to the Q&A, just to remind people to submit for your CME credits either under Section 1 with the Royal College of Physicians and Surgeons of Canada or with the College of Family Physicians of Canada. So I noticed we have one question in the chat, actually, from Melissa. Did you see a particular anxiety disorder, generalized or social anxiety differentiations?
So the way the data was coded from Alberta Health was related to diagnostic categories. So what we can highlight is that anxiety disorders as a whole increased. However, they did not, we couldn't actually split up necessarily individual diagnoses given the size of those sample sizes. So again, not clear from the current data. If there was further data, I think we could easily tell that difference, but not based on the research that I have.
And I guess I just had another question. Like, do we know the diagnoses by specialty? Because there's family physicians,
Mm-hmm.
pediatricians, child psychiatrists, all seeing these
Mm-hmm.
kids. And did that break down in terms of uh, who saw these kids or not really either?
It didn't because again, they're trying to limit. We're trying to highlight like that anonymity and limiting those differences in that same sense. The challenge becomes exactly that: is that when a child sees a physician, whether it's family physician, pediatrician, or psychiatrist, those three would all be related to the mental health coding that happens. And therefore, we can't necessarily tell who made the diagnosis.
Okay, sorry, before we go on to the next question, just a reminder for people to complete your evaluation form. So the QR code is on screen, or you can click on the link there. So we have a next question. It's good, lots of questions. What is the data telling us about the changing psychological landscape for youth, and what is it not capturing, in your opinion? So,
Yeah.
and is the rebound beyond pre-pandemic levels a temporary aftershock or the emergence of a new baseline for demand, do you think?
Yeah. So I'll answer the first question first. The data is highlighting the psychological distress I think that our youth are experiencing from like our research and then other research groups that are looking at pediatric mental health. A lot of this stems from, the impact of social media and the influence of, limited in-person interactions and how that might impact things. But in addition to that, the changing landscape in terms of how we socialize and how that in itself over the course of 2 years in childhood or adolescence and how that might impact the ability to relate to others might be a big piece that might be captured. In addition to that, I think one of the pieces that stands out is that even prior to the pandemic, we were seeing that every year there was an increase. So why that might be, it's really unclear. However, thinking about the pressures and stressors that have been increased over the course of time with youth in terms of some of that uncertainty might also be what's captured. So those are my initial thoughts, at least. In terms of, the rebound beyond pre-pandemic levels, we're waiting for data for 2023 and 2024, hoping to get 2025 data. There's been some changes in terms of Alberta Health allocation of access to that data for research purposes. Um, Based on other jurisdictions and where the levels are looking like now, it looks like it might be a new baseline. There has been some jurisdictions that have shown a slight decrease from that initial, we can call it an aftershock related to the pandemic, but again, not going back to those pre-pandemic levels. And so we're thinking that this might be a new baseline. What that looks like for Alberta, again, is uncertain because we haven't had the data to analyze in that same sense. But we wonder if this is going to be, again, a new baseline, again, highlighting the demand of our services as well.
So, Dr. Yu says, thank you for the lovely presentation. And she's curious about what kind of data is being gathered from schools and other jurisdictions, and is it health data, and who is gathering that data, whether it's a clinician or a teacher.
Yeah. So some other jurisdictions, they have education related data, and that could look at academic performance, school absenteeism, um, use of like rehab services has also been something that other jurisdictions have gathered. So like SLP, OT intervention, um, instances of like agitation in the classroom. And so some other jurisdictions have access to like day-to-day type data or service use or school absenteeism, presenteeism, however we want to look at it. So it's not necessarily health data in itself. However, if in some jurisdictions, when you have access to education related data for individuals such as our children and youth, and you can combine that with, what we're seeing clinically in terms of some of that diagnostic piece or a presentation to emergency departments. And sometimes even others will have access to like social services data in terms of, number of calls to social services, use of social services in general, including need for supportive housing, et cetera. Sometimes it allows for cross-discipline collaboration, but also to give a better landscape in terms of what the system as a whole is facing and how that might be driving trends across different jurisdictions of a person's life. So again, it depends on which jurisdiction we're thinking about, but that's usually where those what that data looks like.
Thank you. And so there's someone from personal experience here. Um, I noted that you said that the data is a year old. In my work at the ADAC shelter, that we electronically record everyone. They must, it sounds like they turn people away due to space, and that this info should be coming to you shortly. And I guess, have you been receiving it so that this vulnerable, impoverished population can hopefully receive more help?
It's a great question. Um, Again, I think it depends what source we're accessing. So we used Alberta Health data for this research. And so I'm not sure if the ADAC shelter data would actually go into that same category. It's likely gathered slightly differently. So I wouldn't have access to that data. I think it does highlight our system and where that capacity lies. Um, Access to treatment, as I was mentioning, especially for substance use, again, has had significant impacts and how that might impact the desire to come forward and even identify substance use in the first place. And so I think it's just highlighting as well, Anna's, that um, our system in many sense is really at capacity or over capacity. And so I think part of that becomes, how do we improve access? What does that look like? Um, And yeah, I think any kind of ways to improve access to data like this to guide system change is critical. So we can always connect later as to what that looks like.
So I have another question, and I don't know if you can tease this out from your data, but I guess I've heard from clinicians who see kids on the spectrum, so part of that neurodevelopmental disorder. Um, that I guess what I'm wondering is if there is a interaction between, let's say, a particular diagnosis like ASD or neurodevelopmental disorder and anxiety disorders, because it sounds like people have noticed that maybe some kids actually do better at home during the pandemic, and maybe some with anxiety disorders as well, where some do worse. And so can we tease out some of those I guess diagnostic or interactions?
So I think the way I did the data, we couldn't do it from my specific analysis. However, um, if I was to request the data slightly differently, there is that opportunity. So we're looking at, again, separate to this, but and with a different group to look at like comorbidities with substance use disorder and how those might overlap. So similarly, we could do that with neurodevelopmental disorders and pull specifically some of those overlapping pieces. I think your point is very well meant because our initial thought was that there might actually be a reduction in anxiety disorders over the pandemic because people who have anxiety disorders now don't have to face their component of anxiety. And so for us, when we've seen a significant increase in the way it was, I think that highlights how distressing the pandemic was overall. Even despite, our kiddos with social anxiety now not having to go to school or, families are now home, so we have less of that generalized anxiety. So it is possible, just not with the way that we got our data from Alberta Health at this point.
Yeah, that'll be absolutely interesting. As someone commented, if we are able to differentiate, is it that generalized anxiety disorder increases and maybe some cases of social anxiety decrease if we're able to separate that enough. But yeah, this is, as we are now, a provincial health system, um, do you think that um, like what changes in data collection, or what do you foresee? Because it sounds like there's a trove of data, but you have to be able to access it in a way that's usable and provides insights, right?
Yeah, I think the challenge right now is in 2020, late 2023, early 2024, the government actually limited access to data like this
Oh,
for research
really?
purposes. And so it's not necessarily related to Recovery Alberta or other health divisions such as that. They actually limited access. So that's been a big challenge in terms of accessing further post-pandemic data groups in terms of being able to identify, is this our new baseline in Alberta, or are we getting back to pre-pandemic levels? And I think when we think about resource allocation, service delivery, that becomes quite a challenge, especially when we're already dealing with retrospective data in itself. So those are just some things that I think beyond healthcare that kind of goes into politics and access to data can really impact what this looks like in terms of how do we best utilize our small group of child psychiatrists in the best way possible to meet the needs of our group.
Yeah, that's interesting that the government restricted it. Huh? Okay. Um, there, Anna Wilson says, can we work to improve your access to this data? So maybe it sounds like there's someone who maybe take that name and uh, maybe they can, because it sounds like they might be encountering the same issues as you have. Terrence says, thank you for your presentation. And Dr. Rabi is asking, have you found a direct correlation between increasing social media use and increasing mental health rates?
So we didn't look specifically at mental health or at social media use. Again, that is where I think some of that cross or interdisciplinary gathering of data can be really helpful. Others have looked at social media use and mental health rates, and there has been increases of mental health rates, specifically more mood and anxiety disorders, um, related to increased social media use and more on that extreme or higher side of use. So we're thinking about like 8, 10 hours a day is where some of the data does highlight that piece. Again, I think this just again highlights how helpful it is to have data that goes and crosses disciplines and how that can really shape some of our postulations and hypotheses and how that data in itself of like this could lead to this might actually shape how we counsel parents and how we counsel kiddos as well.
Yeah, and you know what? At this point, I'm going to take the opportunity to put a plug for Dr. Natalia Stabila, another one of our wonderful subspecialty residents who is actually presenting on the impacts of social media on children and adolescents and their mental health. And that is in May of 2026. So looking forward to that. And maybe she can answer some of our questions about social media impacts. Okay, so Dr. Stoti says thank you. And his name is Michelle and Carol. So, yeah, I mean, this is like a pretty rich discussion, and it sounds like there's a number of directions that this can take, but also, um, yeah, if you can collect that data and I guess in some sense mine it so that we can, impact our health service delivery. I mean, from what I gather, this government, and it's interesting why they're restricting data, but I think they also want data points. So I don't know if there can be some advocacy because I know that that's also something you're interested in. Saying, hey, if you give us the data, then we can better, let you know if your services are, let's say, effective, efficient, and yeah, but it's hard to do that if we don't have the data, right?
Exactly.
Okay, Dr. Stivila also says, great talk, Jacquelyn. Support from your colleagues, peers here. So, okay, I don't see any other questions. And so, yeah, thank you again. And I'm sure we'll, continue. I hope we can continue to look forwards to hearing more from you and from this area as you continue your work.
Thank you so much. Thanks everyone for joining.
All right, and Dr. Derry says thank you as well. Okay, bye.